Good morning. Welcome to our discussion on pediatric endocrine disorders. The first thing we want to look at is hypopituitarism and panhypopituitarism. And this is a condition in which one or more hormones secreted by the pituitary gland is deficient. Remember that growth hormone is the most delicate of all the 6 hormones produced by the pituitary gland, and it's also the first to become insufficient when the gland is damaged. This can occur as a result of trauma to the head during delivery, such as think of like the forceps when they pull the baby out, or maybe baby's head got stuck in the birth canal. Can also be because of tumors of the hypothalamus or pituitary, can be caused by infectious diseases in the central nervous system, chemotherapy, radiation, surgical resection, and congenital syndromes. Children with growth hormone deficiencies have a clinical presentation of delayed growth of less than 2 inches, which is 3 to 4 centimeters, so 2 inches per year delayed growth. And this is monitored by plotting the serial growth plots on the growth chart for their age and sex, which is one more reason why we want to make sure that we are plotting those kids out every time they go into the doctor's office. Children with growth hormone deficiency have consistent decline of growth measurements on the growth chart over time, and a high weight to height ration with increased abdominal fat. And infants can also have a delay in the closure of their anterior fontanelle. Other signs and symptoms may be delayed teething or dental eruption, decreased muscle mass, cherub-like appearance or appearing to be younger than actual age, delayed puberty during adolescence, and a high-pitched voice. And there is a great YouTube video on this link that I encourage you to click on and watch because it gives you a lot of good information. Diabetes insipidus. Don't confuse this with diabetes mellitus because it's completely different. But diabetes insipidus is the insufficient production of the ADH, which is also the antidiuretic hormone. And the ADH is stored in the posterior pituitary gland, and it acts on the kidneys to restore water and control the amount of urine excreted. So there are 2 different forms of diabetes insipidus, which is central, or also known as neurogenic, and nephrogenic. So your central diabetes insipidus is caused by insufficient ADH production. Nephrogenic occurs when the kidneys fail to respond to appropriate levels of ADH. And both forms of diabetes insipidus can have an abrupt onset and similar manifestations. Hyperpituitarism is a rare condition characterized by excess growth hormone secretion from the pituitary gland, and this causes children to experience uncontrolled growth. If the patient has precocious puberty in conjunction with hyperpituitarism, the condition may be caused by a tumor on or by the hypothalamus or pituitary gland. And once the closure of the epithelial plates occurs and hyperpituitary continues, then overgrowth of those bones can occur. And this is referred to acromegaly. And acromegaly is enlargement of the hands and feet and coarseness of facial features, including the forehead, nose, lips, tongue, and jaws. Other symptoms of hyperpituitarism can be generalized muscle weakness and pain in the muscles and joints. Just think, if things are growing at an abnormal rate, you're going to just have the more muscle pain and weakness and joint pain and weakness. Syndrome of inappropriate antidiuretic hormone, or SIADH, and this occurs in the presence of excessive ADH production, and the kidneys are unable to conserve appropriate amounts of water, so the body retains the water, leading in water intoxication, hyponatremia, which if you don't remember is your low sodium, and cellular edema. SIADH is very closely associated with children who have had CNS infections or intrathoracic disease and may occur in post-op patients as a complication. The signs and symptoms have varying degrees of seriousness. Excessive SIADH may include nausea, vomiting, seizures, and personality changes such as irritability, combativeness, hallucinations, and confusion leading to stupor or coma. Other signs and symptoms may be increased blood pressure, neck vein distension, crackles heard on the lung examination, weight gain with no visible edema, decreased urine output, and you're going to see that decreased urine output despite a high urine-specific gravity and low sodium levels. And this is a great little chart, guys, that looks at DI versus ADH. And so it really kind of shows you the difference. Precocious puberty. This is defined as early puberty development in girls younger than 8 years and boys younger than 9 years. It can be caused by premature release and secretion of gonadotropin hormones from the pituitary. There are 3 classes of precocious puberties, and this can be found in your book. You can have complete or true precocious puberty. You can have incomplete precocious puberty, and you can have puberty caused by other conditions such as injury to the central nervous system. But signs and symptoms, you're going to have presence of breast development, which if you remember from your Tanner stages is a stage 2 or greater for girls younger than age 8. And you're going to see presence of testicular development, which again is a Tanner stage 2 or greater for boys younger than 9. If you remember on your stage 2, the scrotum is reddened and thinner. You have stage 2 pubic hair that's growing. On females, the vaginal mucosa is pink and thicker. On both sexes, you'll see sebaceous activity on the face, such as acne. You're going to see café a la spots, which is the presence of bone lesions on x-ray. You're going to have advanced bone age, and that's where the bone age on an x-ray of the left hand and wrist in comparison with the chronological age. Increased height velocity, GnRH or gonadotropin releasing hormone stimulation test results. These kiddos will often have an increased luteinizing hormone or LH, which is greater than 10. You can do leprolide acetate stimulation test, and you often see with that the LH levels are greater than 8. And this is another great little chart. I really like this because it helps just put that out there. Thyroid disorders, you know, we think of those as adults, but they can definitely happen in kids. You can have congenital hypothyroidism, and this occurs at birth. And because it has such profound effects on the infant, we now have state newborn screening programs. And so everyone, all newborn babies are required to have this screening. And just so you're aware of those profound effects on the newborn can be cognitive. Acquired hypothyroidism can be an onset in childhood or teen years, and it can be related to an autoimmune condition known as Hashimoto's thyroiditis. Medications such as lithium may interfere with thyroid synthesis. And then again, hyperthyroidism, and this is the overproduction of thyroid hormones, often referred to as Graves' disease. It occurs most frequently in teens between 12 and 14 years of age, and it does tend to run in families, and typically you see it, the signs and symptoms within 6 to 12 months. However, if untreated, it can cause lifelong complications to the body systems, especially the eyes, the CNS, and the GI tract. The thyroid storm is a life-threatening condition that requires medical intervention, and this can occur if symptoms go untreated for a long period and become severe. And then on your PowerPoint slide here, it really shows the difference between the hypothyroidism and the hyperthyroidism. So just you know, the way I kind of remember this is hypothyroidism, the metabolism is slow, so you're going to be intolerant to cold. You're going to have weight gain, facial and eyelid edema, the dull blank expression, fatigue because that metabolism is so low, thick tongue, slow speech, anorexia, they're not hungry, brittle hairs and nails. And then late clinical manifestations, if they're not being treated, of course, is your subnormal temp, bradycardia, decreased level of consciousness, weight gain, thickened skin, and cardiac implications. Whereas your hyperthyroidism, you know, they're just going. So they get the bulging eyes, facial flushing, enlarged thyroid, tachycardia, anxiety, weight loss. So lots of different things here. And then, of course, our traditional diabetes mellitus. Remember, our type 1 is caused by the destruction of the beta cells in the pancreas. And the pancreas is an organ that produces insulin that regulates blood sugar levels in the body. When the beta cells are destroyed, the pancreas can no longer produce insulin, so glucose levels in the bloodstream are too high. Children with type 1 must have exogenous insulin, so your tablets of your sensitizers are not going to work because they're not producing insulin. So they are actually going to have insulin injections. So they can result from genetic influence, autoimmune mechanisms, any autoimmune that affects the pancreatic islet cells, and viral illnesses that attach and destroy pancreatic function. Type 2 diabetes mellitus, and this is the one that's most popular, and we see this coming a lot more with our kids as the obesity rate continues to climb, but that's where the body becomes resistant to insulin production from the pancreas. So basically, your pancreas is overstimulated, so over time it starts getting desensitized, where you can give them medications like your glucophage that makes your pancreas more sensitive. However, just remember, if the patients don't get that blood sugar under control, within 5 years, typically the pancreas stops working at all, and then they do have to go on insulin. Risk factors: obesity, sedentary lifestyle, family history of diabetes, poor dietary intake, especially if they're eating a lot of high carb, simple sugar foods. Kids with type 2 doesn't typically have symptoms, and even when the condition is diagnosed. But so any child with a BMI more than 85 percentile of weight and height should be monitored for type 2 diabetes, because remember, your obesity is the #1 predisposing factor, followed by your hypertension and high cholesterol levels. And this is something put out by OSF Healthcare that I really liked. On average, children diagnosed with type 1, type 2 diabetes are 13 to 14 years old, but type 1 can be much earlier, and that's usually because those kids go into ketoacidosis and have to be put in the hospital.